and college credits are available through George Washington University for viewing Emergency Medical Update.
Hello, I'm Cliff Lenz. This month on Emergency Medical Update, we bring you an up-close look at frostbite to help you prepare for the winter months. And our team treatment series continues with cardiac monitoring. But first, we take you to Boston, where a high-rise fire forced the evacuation of over 3,000 people from a 61-story building. How did EMS responders cope? We bring you this report. August 11th, 1992 started like any other day at the John Hancock Building in Boston. But all that changed when a fire on the 7th floor forced a full evacuation. The emergency generator failed, and the smoke-filled stairwells were plunged into darkness.
Hey, what's it like up there?
The whole thing is an unbelievable experience.
Yeah? Was it scary?
Very, 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 very scary.
As people made their way down 60 flights of stairs through toxic smoke, fire suppression got underway. Boston EMS Deputy Superintendent Richard Serino assumed the role of EMS Incident Commander.
Initially, the call came in for a report of a fire at the John Hancock Tower. That's all the information we had. There were no injuries. The fire department got it initially. It's a still assignment, not that severe.
That report turned out to be wrong. Commander Serino immediately asked for more responders, knowing the situation could quickly escalate. Robert Freitas, acting director of training,
responded arriving a couple minutes later and was actually given the assignment of the operations officer, which really reports directly to the incident commander and assembles information about the whole aspect of the incident, how the treatment area is going, how the loading area is going, and feed information to the incident commander so that he can get a better scope of the situation.
EMT Jamie Orsino was assigned to the transportation or loading area.
And as we pulled down towards the end, we were setting up a loading area. I noticed that smoke was coming out of the vents for the mechanical floor. And there also weren't a lot of people evacuating at that time for a building like the Hancock, several thousand people in there. Then we came to realize that the power was out, knew the elevators wouldn't be working, the lights wouldn't be on, the vents probably wouldn't be working as well. And we worried about the people that were above the 7th floor.
Paramedic Paul McGilvery was on the first ALS unit to arrive and was one of 2 triage and treatment officers.
I believe between the 7th and the 12th floor there's quite a bit of smoke, so anybody above those floors encountered I believe some pretty scary moments coming down the stairwell. They were not receiving any direction, nor did they know what the problem was. Also, they know that the stairwells were beginning to fill up with smoke, but they were uninformed as to the nature of the incident.
I was on the 26th floor, so I came down from 26, and it was pretty smoky when we entered the stairwell on the 26th floor. Scary, really scary.
Very early on in the incident, it was determined that there were people exiting the building from both sides. Initially, when myself and Paul, who was my partner, arrived at the incident, we were directed by the incident commander, Deputy Serino, to set up treatment areas.
2 treatment areas were established on opposite sides of the building. The incident command post was set up in the large plaza in front of the building. There, fire, police, and EMS commanders worked together to direct the response. The transportation or loading area was along Stewart. The staging area was located on Stewart as well, further back from the incident. A total of 19 ambulances from Boston EMS and 3 private companies were called to the scene, along with 53 EMS responders. Boston EMS had prepared in several ways for an incident like this one.
Any community that has EMS should have an incident command system in place, work with other agencies and practice and drill. The fact that we had a drill there last October helped a tremendous amount, that you were able to know parts of the building, able to know what to expect. Just simple things like on the plaza at the Hancock, that we couldn't drive on it because just below, it's just a false sidewalk below it is their cafeteria. If you drove on it with a couple of ambulances or a fire truck, it's going to collapse.
The Hancock Tower has its own security force, trained at the State Fire Academy for evacuation. The 125-member force played a critical role in communications when emergency generators failed. They became messengers, walking up 61 floors to alert workers of the need to evacuate. They helped maintain a sense of calm among evacuees.
Everybody walked down single line. They told us to stay to the right. Everybody stayed to the right. It was real good. Nobody panicked or anything like that.
But triaging 3,000 people wasn't easy.
You feel like you need some oxygen?
No, I'm fine.
You sure?
Yeah.
Okay.
Because we were located close to the front door, everyone, victim and non-victim, came out together. So it was kind of hard to discriminate between the people who were actually victims and the people that were just leaving the building without any injury.
Boston Fire Commissioner Martin Pierce Jr. told us the fire was confined to the 7th floor, with smoke spreading from the 5th to the 10th floor. Miraculously, the building was successfully evacuated with few injuries.
We transported a total of 29 patients. We treated an additional 43 patients on scene. So we treated a total of 72 patients. We went to a total of 6 area hospitals.
It was a hot and humid day, and the injuries sustained were those you might find at any high-rise evacuation. Dehydration, asthma, and chest pains brought on by pre-existing conditions, such as cardiac or respiratory problems. Some aspects of the incident went very well.
Every patient that was identified was treated fairly rapidly. I think that our ability to treat large numbers of victims with scant resources is very strong.
I think a lot of what went well at the Hancock fire was a lot of the communications that went on between the departments, also within our own department. Also, the hospitals were notified very early on via CMED. They received updates all the way along to know what was going on, to let them know the severity and whether the incident was progressing, whether it was de-escalating.
In the incident critique, lessons were learned and some safety issues were addressed. For instance, falling windows were a problem which plagued the Hancock Tower when it was first built.
I might have moved the treatment area a bit away from the active incident area, away from the Hancock building. With any incident of this nature where there's fire involved and pressure builds up, there's always the danger of windows being knocked out and falling on people below.
One of the things that's difficult in this kind of operation is that you have a tendency to drill for the expanded incident command system, which talks about discrete operations officer and logistics officer and planning officer and communications officer. But what happens, depending on the size of the incident, is you'll combine the different positions together, and it can be difficult to keep track in your head what exactly your role is.
When a second transportation area was added, Bob Freitas switched from operations officer to transportation officer.
There were problems tracking patients, due firstly, I believe, to the difficulty I had remembering initially that I transitioned from the operations officer to the loading officer, and it was unclear in my mind that I had changed positions, and the first couple of patients that ended up getting assigned from that location, no one kept track of.
Gearing up for an MCI isn't easy. Preparation may include identifying high-risk areas where an MCI would be the most disastrous, drills in the high-risk areas, drilling with all other emergency service agencies in your area. Use the incident command system regularly on smaller incidents. Practice using vests or hats to identify officers, and get to know disaster plans already in place in local industries and buildings.
I learned that within our own system we have to do more education for some members of our own department to know the incident command system a little bit better. The incident command system works if everybody knows their roles.
Keeping perspective as the incident progresses will also help you use the incident command system to your best advantage.
A building like the Hancock is huge. It's connected to other buildings, and you can't just look at the front door or the back door and the people that are streaming out. You have to look at the whole picture. Be looking around for treatment areas, be looking around where the other people are going. It's a big picture, and you have to really stand back and look at the entire situation rather than just, well, here comes 60, 70 people right at me out the door. You have to be able to deal with thousands of people at that point. So just step back and look up and realize how big it is, and stick with the system. That's what it's designed for.
Okay, folks, got moving all the way up to the sewers meet.
Our thanks to the responders in Boston and to John Hancock Financial Services for helping us bring you that report. As winter sets in, the types of injuries you see may change. Frostbite can cause devastating tissue loss. The way you handle frostbite injuries will have a serious effect on how completely they heal.
Exposure to cold can lead to serious cases of frostbite, sometimes resulting in loss of limbs. Generally, this injury affects cheeks, nose, ears, hands, and feet. When heat is lost faster than it can be replaced by circulating blood, ice crystals form within the tissues.
And those ice crystals that can then cause destruction of the small vessels, the capillaries, which when they thaw cause leak and further destruction of the tissues and compromise of circulation. So it's basically absolutely freezing the tissues, whether it's superficial or deep.
210 C8 bump. Yeah, Terry, I've got a female skier here complaining of numbness in the foot. Also has a broken binding. I think we need a sled down here for a courtesy ride.
Frostbite is a progressive injury with 3 stages. Incipient frostbite, or frost nip, usually involves only the tips of the nose, ears, cheeks, fingers, or toes. At first, the skin is red, then turns white. The skin surface is soft, as is the tissue under the skin. Frost nip does not require emergency care. It's often treated by the victims themselves by rewarming the injured area with their own body heat. Superficial frostbite affects the skin and tissue just beneath the skin. While the skin itself is firm, white, and waxy in appearance, the tissue beneath is usually soft and numb. Deep frostbite or freezing is the most severe stage of frostbite. The surface of the skin appears blotchy and may range in color from white to yellow to grayish blue. The tissue below the surface of the skin will feel solid. Deep frostbite can result in permanent tissue loss. It is considered an extreme emergency.
Initially, frostbite is difficult to assess. Some hands or feet that look terribly frostbitten may in fact be very salvageable, which is the key thing. Treat them all the same as if it were severe.
Frostbite may also occur when there's been contact with cold metal, such as car door handles, mailboxes, or jack handles. More severe injuries are caused by contact with organic liquids like gasoline or solvents which have been left outside in temperatures below freezing.
Water's a solvent, and water, when it evaporates, obviously cools the tissues, but a more potent cooling agent would be like gasoline, ethanol, things like that, benzene, that when it comes in contact with the skin then cools very rapidly and predisposes at least to superficial frostbite.
Okay, Leslie, we'll have you
Here you
step
go.
into the toboggan and sit down and then lay back. There you go.
Got a pillow for your head right here, Leslie. Just go ahead and lay back.
Go ahead and put your knees down. Probably take about 10 minutes, and then you'll be in the base area, and we'll start taking a look at that foot. Warming up.
Risk factors that increase the likelihood of frostbite are traumatic injuries in cold weather, age, elderly and newborns are more susceptible, alcohol use during exposure to cold, wet clothing, high altitude, tight footwear, blood loss, diabetes, circulatory disorders, and race. Blacks are 3 to 6 times more likely to get frostbite than whites.
Okay.
Okay, Leslie, we'll take you in this room right here and get some of that stuff off and begin to take a look at your foot and warm you up.
How's your other foot doing? Any numbness in your other foot at all?
No, it's
Just in the one.
It's difficult to assess severity of frostbite. All cases of superficial and deep frostbite should be considered serious. Transport as soon as possible.
You're going to take your sock off now, Leslie.
Protect the frostbitten area and handle as gently as possible. Never rub the frostbitten area. This could result in permanent tissue damage.
Oh yeah, it looks like you got some frostbite down there. Can you feel any of this?
I can't really feel it.
Okay, all right.
Walking should be avoided if any part of the feet is injured. Remove the patient from the cold environment and keep them warm. When transportation is delayed, emergency care calls for rewarming the injured area. It's a good idea to consult your medical director before thawing a frostbite injury.
The importance of early thawing really hinges on the fact that the sooner you thaw the tissues, the less damage will be incurred thereafter. In other words, the longer they're frozen, the more the tissues will be damaged. So early thawing, if possible, with non-traumatic evacuation is the important factor to decide at the scene.
If the victim has to evacuate on their own, or there is a chance of prolonged exposure or refreezing, do not attempt to thaw the injured area.
Refreezing is quite a bit more traumatic to the tissues because once they've thawed, they're edematous, the small capillaries are damaged, and freezing them then in that state really leaves a much more damaged digit down the road.
Remove any clothing, constrictive bands, or straps which may interfere with circulation.
I've seen worse than this, but it's just important to get something like this warmed up as soon as possible. Does that hurt?
Yeah.
Thaw the tissue rapidly in water, just above body temperature, 100 to 105 degrees Fahrenheit. Water should feel warm, but not too hot to touch. Use a container that's big enough to fully immerse the injured part without it touching the sides or bottom. It's important to maintain a constant temperature which is evenly distributed. As the water cools, continue to add additional warm water. Remove the injured area before you do this.
That feels good. Ready, Leslie?
Yeah.
There you go.
Here we go.
Getting tingling out of the water now?
Yeah.
Okay.
It hurts a little bit.
What we're trying to do is rapidly rewarm it, so you're going to feel some pain, but the best way
As
to do
thawing
that is
occurs, the patient may complain of pain. Continue rewarming until the injured area is deep red or bluish in color and no longer improves. Skin should be soft and pliable.
Okay, Leslie, I need to take your temperature. We want to make sure that you're normal.
During rewarming, keep body temperature up by providing a warm environment and warm drinks. Only give fluids to alert patients.
Good, Terry. She's normal, 98.6.
What we're going to do is bandage in between all your toes here, Leslie. That'll keep them from rubbing together and causing...
Once the area is thawed, place sterile pads between the fingers and or toes to prevent friction that contributes to tissue damage.
How's that doing?
Still hurts.
Still hurts a lot.
Do not break any blisters that may have formed. Elevate the injured area.
I'm sure you'll go to a hospital and have a doctor check that out. 124/80.
As the patient is transported, keep the injured area warm and elevated. Provide whatever life support measures are needed. If feet are involved, the patient should not be allowed to walk. Frostbite is often accompanied by hypothermia. In these cases, treat hypothermia aggressively. Please see Emergency Medical Update Volume 3, Number 4 for information on hypothermia care. Consult your medical director for the local protocols on warming frostbite injuries. Did you know as many as 60% of all antibiotics are misprescribed? Antibiotic medications can cause adverse side effects and complicate your assessment. How can you recognize these side effects? Let's take a look. Antibiotic drugs are used to help the body fight infection. These medications are broken down into two categories: bactericidal, which kill the infecting bacteria, and bacteriostatic, which halt the growth of the bacteria, giving the body's own immune system time to fight the infection. Some examples of antibiotic agents include penicillin, gentamicin, known as garamicin, neomycin, sold as misotracin, amikacin, known as amikin, and kanamycin, known as Cantex.
These agents are prescribed to destroy microorganisms which have caused an infection in the body.
Recent studies have shown that antibiotic medications are commonly misprescribed in the United States. Some antibiotics are given in situations where the infection can't be treated or the wrong antibiotic agent is prescribed. This misuse of antibiotics can cause side effects in those who use them.
The major concern of antibiotics is acute allergic reaction, especially to the penicillins and sulfonamides or sulfa agents.
Along with possible allergic reactions, other adverse side effects can include stomach irritations and diarrhea. As bacterial strains become resistant to certain antibiotics, development of new forms of antibiotic treatments will increase. With this, the dangers of misprescribing may continue.
The EMS Pocket Drug Manual by Jones and Bartlett Publishers is an excellent reference for more information on medications. You may become an EMS provider because you are interested in medicine, or maybe you just wanted to help people. In any case, you probably didn't bargain for the fact that more and more EMS providers are being called to appear in court. It may never happen to you, but in case it does, you'll need the information in this next segment, Preparing for a Trial.
It seems every time you turn around, there's a new lawsuit being talked about in EMS. As more patients and families take to the courts, chances are you'll be called to appear.
That's a subpoena to appear for a deposition.
Where?
The information, all the information you need, you can get from the attorney whose phone number is on the papers.
Okay, I'll give him a call. Thanks a lot.
Even EMTs who provide excellent care and carefully document each call can become nervous when a subpoena arrives.
Sometimes an EMS provider will have the opportunity, or more accurately, be compelled to testify in a civil or criminal case as a witness. It's important that we understand as EMS providers what our obligations and duty are in such cases.
Hi, Cap. This is Larry. How you doing? Sorry to bother you. I just was served a subpoena by the county.
A subpoena will command you to be present and sometimes to produce certain records at a location. If you are subpoenaed, you should notify your supervisor and medical director. Discuss compliance. Is it appropriate for you to be present at the time requested and to produce any records requested in the subpoena? These records may belong to your agency, the receiving facility, or a doctor. Consult your agency's legal advisor if your agency has one. They may wish to attend to represent your interests. You may be called to give evidence at a deposition or at a trial.
Mr. Marvin, could you tell me how you first heard about my client's injuries?
A deposition is less formal than a trial. Those present will include a court reporter or video operator and the lawyers representing both parties involved. This meeting may be held in an office or conference room rather than a courtroom. A trial is more formal, and you'll give testimony in a courtroom with a judge and possibly a jury present.
I encourage the paramedic or EMT, if they're concerned or apprehensive about such testimony, to go into a courtroom and observe a trial before they testify so that they will have a better understanding of how these proceedings go forward.
Whether you are called to appear at a trial or a deposition, there are some basic rules to keep in mind. Look professional. Wear a business suit or your uniform. How you look will affect how seriously people take you. Review the facts of the case. At a minimum, read over the run report or patient care record. Try to remember the circumstances as best you can. During your testimony, be as impartial as possible and present facts and expert opinions in a concise, logical way.
And it is always important in a deposition or any type of setting where you're offering testimony, of course, and primarily to always be truthful. Listen carefully to the question that is asked to you and answer only that question. Do not provide additional or extraneous information that you're not requested to provide.
You may be asked a question you don't fully understand or that you don't feel qualified to answer.
At any time during your treatment of my client, was he intoxicated?
It's entirely appropriate in that setting, in that situation, for the paramedic or EMT to simply say, "I'm sorry, sir, I don't understand your question, and or I don't feel that I'm qualified to answer that question because I don't feel that I have sufficient information or sufficient training."
In general, testimony about someone else's actions given under oath cannot be used as a basis for any type of claim or cause of action, such as a slander suit. But what do you do when you leave the courtroom and are questioned by a reporter about your testimony?
Can you tell us if the judge was drunk while he was driving?
I'm not at liberty to tell you any of that kind of information.
Okay.
You have to say, "I'm sorry, I'm not at liberty to discuss that with you." You need to direct that inquiry to the medical director of the EMS system.
In this way, you maintain patient confidentiality and protect your patient's rights to privacy, even though it may be very tempting to talk to the press about the case.
But that temptation must be rejected because a professional person such as an EMT or paramedic cannot indulge that type of approach to this issue. It's very dangerous to do so.
Remember, once you are no longer under oath, what you say is not protected from claims of slander. What are the most important things to keep in mind when called to give legal evidence?
Again, it is very important for the paramedic or EMT to make a good professional appearance, not to take sides, and to present their testimony in a competent and professional fashion. And in general, be the kind of a witness that you would think was credible if you were on a jury watching that individual testify.
Cardiac monitoring, interpreting the ECG, administering cardiac medications. All of this has nothing to do with you as an EMT, right? Actually, on hectic scenes, while paramedics are trying to insert an airway, start IVs, and hook up the cardiac monitor, you can play a vital role in attaching the patient to the cardiac monitor. Paramedic instructor John Politis helps us demonstrate ways BLS providers can facilitate cardiac monitoring.
Just as the pulse rate and blood pressure help you assess the mechanical ability of your patient's heart, the best way for paramedics in the field to assess the heart's electrical activity is to monitor the electrocardiogram, commonly called the ECG or EKG. Usually there's plenty of time to attach the monitoring leads, but in some cases, you, the EMT, can save valuable scene time by turning on the monitor, placing the electrodes, and attaching the patient to the ECG monitor. The ECG is an electrical representation, or picture, of the heart's rhythm. Each component of the ECG complex, that is, each blip on the screen, represents an event in the heart's cycle. When the heart beats out of rhythm, it's called dysrhythmia. Arrhythmia means there is no rhythm. This is also called asystole. Paramedics are taught to recognize and treat life-threatening cardiac dysrhythmias. But an ECG does have limits. It's difficult to determine if a patient is having a myocardial infarction, or MI, from an ECG taken in the field. The diagnosis of MI is based mostly on the patient's history and analysis of cardiac enzymes and a 12-lead ECG. Just because the patient has a visible rhythm on the monitor doesn't mean they have effective blood flow. This must be assessed by checking vital signs. You should become familiar with the defibrillator monitors used in your area. All units have the same basic features: an on-off switch, a QRS height adjustment for calibration, volume adjustment for ECG complex beep, a battery, ECG paper.
Two of the most common monitoring lead positions that are used in the United States are lead number 2 and modified chest lead number 1. My teammate is going to demonstrate to you the application of leads for lead 2 electrode position. First thing he's doing is he's turning on the monitor for me. He's taking out the patient electrode cables, and he's also selecting a set of electrodes. These are prepackaged electrodes. They're the best type to use because they're less likely to be dried out. This will allow you to be able to get the best electrocardiogram because they have the freshest electrode jelly. I'm going to apply 3 monitoring electrodes in the lead 2 configuration. One is applied over the right shoulder, one is applied over the left shoulder, and one is applied on the left lower ribs. The red cable that's being attached is a positive monitoring electrode. The black cable that's being attached is the ground cable, and the white cable that's being attached is the negative cable. And this is the lead 2 monitor position. It's important that these electrodes are properly attached to the patient. Sometimes you'll be attaching these to very, very sweaty patients. It's important that the skin is then dried and something put on the skin, such as an antiperspirant, to ensure that these electrodes will be properly attached to the patient. On patients who have an awful lot of hair on their chest, to ensure proper electrode adhesion, their hair should be shaved away with some type of disposable razor. Once these electrodes are properly attached to the chest, then we can attach the monitoring cables. Again, all machines have some type of monitoring cables.
Remember, when applying AED electrodes, be sure to attach the cables before applying the electrodes to your patient.
If you're an EMT team member, please don't become mesmerized by the cardiac monitor. Each ECG complex does not necessarily result in cardiac output. Good serial vital signs and basic life support management are essential for total patient care. Remember, you're treating the patient, not the ECG monitor.
Sometimes the monitor can be deceiving. For example, not all cardiac complexes result in pulses. If the patient is not breathing and has no pulses, they need CPR, regardless of what the monitor says. The paramedic will interpret the ECG of a patient in cardiac arrest.
Remember, if your monitor has a digital heart rate meter, it's not a substitute for taking the patient's pulse and blood pressure.
Rate meters estimate the patient's heart rate based on an average number of complexes over short periods of time, so they can give false pulse rate readings.
Most monitors have a beeper that activates with each QRS complex. This beeper is a useful tool. However, the beepers tend to make the patient and the family nervous. So unless your medics request the beeper be turned up, they should be turned down low. If the medics that you work with have a monitor defibrillator that can be separated into 2 components, I strongly recommend to you that you leave the monitor and the defibrillator attached to one another. Any patient serious enough to have their ECG monitored may go into ventricular fibrillation at any time, and they may need the defibrillator immediately. When cutting the clothing off a patient who already has the ECG monitor attached, be careful not to cut those cables. The ECG monitor defibrillator is probably your most expensive piece of equipment. Always strap it down securely or carry it firmly in hand. On all types of monitor defibrillators, they all have some type of a battery and some type of a strip chart recorder to record the ECG. Be sure that you know how to change the paper in the monitor defibrillator and you know how to change the battery in the monitor defibrillator. Often, the paper runs out or the battery begins to die right in the middle of a serious situation, and the medics are tied up doing something else, and they may depend upon you to help them out by changing the paper or the battery.
If your service uses an automated external defibrillator, check the compatibility of your monitoring electrodes with the ECG monitoring equipment that your medics use. Drill by running a complex cardiac arrest call with your ALS providers. By practicing running a code in drills, you can become proficient in setting up the monitor, working together with the medics as a team, and doing CPR while moving the patient to the ambulance. Because if it goes smoothly when you drill, chances are you'll be ready when your patient needs you most.
Check with your medical director or training officer for the specific cardiac care guidelines in your area. And now we bring you that wacky comedy duo, the Dysrhythmics, with some medic magic.
Vic and Burn, let it burn, babe.
Yeah, now look, sometimes in between our car washes and video rentals, we get the chance to start PIVALs.
Peripheral intravenous access lines. Yeah, and normally we always start at least an 8-gauge 6-inch catheter as keep open lines on all of our patients. And then the emergency department nurses always know when Vic and Vern coming, they know what to expect.
Hematomas this big from our MUIVAs.
Multiple unsuccessful intravenous attempts. Yeah, anyways, all we do is we just take the IV packaging and we we cut it right where it says the brand and the catheter size.
Yeah, and then you tape it right next to the IV site so the healthcare team knows exactly what you did.
Yeah, what do you think? What do you think? Vic and Vern, helping you learn.
You can receive continuing education credits for viewing Emergency Medical Update from most states and the National Registry of EMTs. Testing requirements and credits awarded vary. Be sure to check with your training officer, medical director, or state office for specific guidelines in your area. College credits and continuing education credits are also available through George Washington University in Washington, D.C. Group discounts for these CE credits are available. More information can be obtained from Emergency Medical Update at 800-327-3841. Take care of yourselves out there, and we'll see you again next month.